Clinical examination of the musculoskeletal system. Movement of the vertebral column, lumbar region. The articular facets lie in the anterior-posterior plane and they lock and greatly limit rotation of the bodies on each other. Flexion and extension are free and a good deal of abduction is possible. Combination of these movements produces circumduction, but practically no rotation is possible. Now we test for the range of spinal movements. In the cervical spine, it tests for flexion and extension movements. And get a patient to touch his chest or his chin as far as possible. And then let the patient extend the neck backwards as far as possible. It tests rotation by turning the head to the right and then the left. It tests the lateral flexion by letting the patient touch the shoulder with the ear as far as possible. It tests for lateral flexion to the left and then to the right. Those spine movements are tested for by chest expansion, and when you use an nipple as the reference point, when you use the position just beneath the breast with the patient's hands above the head, you measure the circumference of the chest with the tape. You let the patient take deep breaths in and out and measure the chest circumference at the end of inspiration and expiration. You make 3 rounds and take the best of the readings. The chest expansion should be more than 6 centimeters in a normal subject. Again, sequential measurements are more significant than single measurements. All the range of movements of the spine originates from the lumbar spine section. It tests for flexion of the lumbar spine by letting the patient touch the floor with his hands as far as he can, and let him lean backwards as far as he can to test for extension. It tests rotation of the right and then to the left, and it tests for lateral flexion by letting the patient touch the outer part of the leg with his arm as far as possible on both the right and the left sides. However, be aware of certain pitfalls as the patient can perform normal flexion despite fixed lumbar spine as the pelvis moves to achieve the movement. To get full flexion in the normal subject, the lumbar lordosis becomes straight. To test for lumbar spinal mobility, spread the fingers on the lumbar spine, and one will find that fingers spread out in lumbar flexion and they are brought close together, extension of the lumbar spine. Rotation movement of the spine is tested with the pelvis fixed and the spine rotated. Let the patient sit on the couch. This fixes the pelvis, and I assess rotation of the spine with the pelvis fixed. It tests for range of movements of the lumbar spine in conditions such as ankylosing spondylitis, and you identify the dimples of Venus at the junction of lumbar 5 and sacrum, and draw a horizontal line at this junction. Then using a tape, you measure vertically a length of 15 centimeters with the patient standing upright, and you mark the point on the skin. Let him bend forward in maximum flexion and measure this length. In a normal person, this length should increase about 8 centimeters. And single measurements are not as significant as sequential measurements, as the sequential measurements give the progress of disease. In ankylosing spondylitis, the measurement should be carried out at the same time of the day, as the patients are stiffer in the morning than in the afternoon. In ankylosing spondylitis, the distance A and B is less. It is for range of movements of the lumbar spine. If a patient has scoliosis on standing, observe what happens on flexion And if the scoliosis disappears on flexion, and it is a recently acquired deformity, and the problems are due to muscle spasm. If the scoliosis remains the same or deteriorates during flexion, then it is a development abnormality. To test the degree of kyphosis of the cervical spine, you get a patient to stand against the wall with the heel, sacrum and occiput against the wall. It is easy in healthy subjects, but patients with ankylosis spondylitis with cervical kyphosis, it's not possible to put the occiput against the wall. So you measure the distance from the wall to the occiput, and this gives a degree of flexion kyphosis of the cervical spine. So now we palpate the neck for cervical, for spinal processes, interspinous ligaments of the cervical spine, and muscles for isolated localized tenderness of or muscle spasm. And also cervical spine problems can lead to referred pain in trapezius muscles and shoulder girdle area, and also interscapular area. To palpate the dorsal spine with firm pressure over the spinous processes for localized tenderness. We palpate the interspinal spaces and laterally for paraspinal muscles. We palpate the lumbar spine in a similar manner to palpate the dorsal spine. Also palpates the paraspinal muscles in the sacrum. Exert firm pressure over the sacrum and coccyx for local tenderness. And the sacral ilitis, the pain is referred to the buttocks and posterior thigh. Induce movements across the sacral joints, and this produces pain in the buttocks and posterior aspects of thighs. Femoral stretch test is performed by the patient lying prone and extending the thigh. In the positive test, there is pain in the back muscles and muscle spasm in the anterior muscle. And the pain radiates to the anterior thigh as far as the knee. Think of root deletion of L3 and L4 in the distribution of the femoral nerve. Further assessment of the sacral iliac joint is performed by firm downward pressure on the iliac crest to induce movements across the sacroiliac joints. The pressure produces pain. Flex the hip and knee and rotate the hip joint laterally and exert firm pressure on the hip along the axis of the femur. This induces movements across the sacroiliac joint, resulting in pain on the buttocks. If the patient has back pain radiating to the leg, especially in the posterior and posterolateral side, that is associated with loss of sensation, this suggests L5 SI root compression.